Well, thank you. Eddie says I have a little bling today, and this is actually a mask that was given to me at the Morgan Nick 25th anniversary of her abduction. The young girl that was abducted in Alma. I was there this weekend for the 25th anniversary, and so I wanted to wear this in Morgan Nick's honor and for the Morgan Nick Foundation. I'm delighted to be joined today by Secretary Nate Smith. Dr. Romero is also with us from the Department of Health, and I have three CEOs from the hospitals here in Central Arkansas. Three of our hospitals: Troy Wells, CEO of Baptist Health, Chad Adoodle, CEO of St. Vincent, and Dr. Cam Patterson, Chancellor at UAMS. And obviously with their presence here, I asked them to be here. We've had a previous meeting on hospital capacity, and even though they're here in Central Arkansas, we've had conversations I've had today with some of the hospitals in Northwest Arkansas, monitoring that very closely as well. I think the main message for Arkansans is that we here in this room take COVID-19 very seriously, and the spread of this virus, the number of cases that we have. That's why we've expanded testing and continue to do that in Arkansas. That's why we're building the infrastructure for contact tracing. That's why we had the guidance that was offered for wearing of masks in the state of Arkansas. And those are the indications that we are working very hard to address this challenge that we face as a state. And I'm very pleased with the reports that I get from across the state that people continually to take this seriously. Obviously, in those areas that you have an increase in cases, they take it the most seriously. And I'm grateful for that, because we all want to get through this. We want to have some level of normalcy in school next year, but we've got to get over this current increase in cases that we've seen. With that, let's talk about the cases in the last 24 hours. Yesterday, we had 15,561 cases here in the state. We have an additional 522 cases. That brings us to 16,083. In terms of hospitalizations, we've had a decrease of 7. That brings us down to 237. Deaths, we've had 2 additional deaths, brings us to 184. We continue to test significantly, with 7,049 tests being done in the last 24 hours across Arkansas. The 3 lead counties in terms of cases over the last 24 hours, of the 522 new cases, 124 were in Washington County. Benton County had 78, Hot Spring County 85, and the rest were under 20. And so that really shows where the challenge is, but also the rest of the state seems to be holding its own. The cumulative positivity rate is 6.3%. We want to be able to see that go down, and that's one of our goals that we have. If we go to the charts, I've got 10 that I wanted to go through today, and the first one, which you see regularly, is the number of new cases in Arkansas. Again, the height over 700. We've had 2 days in that level. Then we see us going down to 500, which down, up that you see. And so it's a spike in trend line. The next one is the 7-day rolling average. We want to see that on a downward trend. Right now it's more on a flat trend, but we've got some work to do there. The next one is in reference to the hospitalizations, and here we veered close to the 250 mark. It's down because of the reduced hospitalizations in the last 24 hours of 7. You go to the next one is the number of active cases. The number of active cases is important because the cumulative total takes us back to March 11. The active cases shows the ones that are testing positive as of today and either are in isolation or some other care. We have a little bit over 5,000 active cases. Next. We will see the percent of positive tests by date of result, and the 10% is the CDC standard, and you can see where virtually every day for the last 30 days or so is way under that, and we want to be able to continue that. And next, we see the 7-day rolling average of percent positive tests in Arkansas. It's very flat. It's just, might be up and down, but it's very flat trajectory. And then next you'll see where I set as a goal 120,000 tests in the month of June. 120,000 tests, and here we are, June 22nd. We've reached that goal of over 120,000 tests being done, which is, we've got more time to continue to do testing this month. In the coming days, we'll announce our testing goals for July as we look ahead, and I assure you we're going to continue to expand that effort in Arkansas, and hopefully the supply chain will keep up with us. And then this is 3 new slides, and I'll end on these, but this is in terms of hospital capacity. And the total hospital beds in Arkansas is available, well, total hospital bed capacity is 8,917, and of those we have the occupied is 71%. The total hospital beds available 2,552, which is a 28.6% additional bed capacity, and this is accommodating both obviously COVID patients, but just as significantly, in fact more capacity is those that are going in for routine procedures and surgeries and other healthcare needs. That is very important to meet that need. And then you see that in terms of ICU bed capacity, we have total ICU beds in Arkansas 970. We have available 222. So again, that's meeting the needs of COVID patients, but also others that have ICU needs. And of course, we want to be able to continue to monitor that, but that shows the capacity. And then the final slide is vent capacity. Ventilators, we have 894 ventilators in Arkansas. We have 583 that's available. So this is different than the other slides, that the available is larger, 65% available ventilator capacity, and we have additional ventilators on order. And I invite Dr. Smith to come to the podium, and he'll might reference these, and then we'll followed by our hospital administrators, who I want to say has really been great partners for us, and I welcome their participation today in meeting the needs of our state. Dr. Smith.
Thank you, Governor. I'll comment on this quickly before I go over some of the other details of the numbers. This is actually very encouraging to me. We're going to continue to watch our hospital capacity, beds, ICU beds, ventilators, staffing, PPE, all these other things. Beds, we do have some ability to expand. We had planned for that back in March and April. We haven't had to implement those plans yet, but if we do, we have a way of expanding beds. We can even expand ICU beds. There are beds that can be, with proper staffing and equipment, be converted to ICU beds or ICU-like beds. The hardest thing to address if you don't have it is ventilators, and so it's encouraging that we do have almost 2/3 of our ventilator capacity is available, and then we have additional ventilators that have been on order. We still have some crisis standards of care that we could convert, for example, anesthesia machines and things like that, things that we had addressed earlier on. But I feel very comfortable that where we are right now is able to handle our expected needs, at least in the short term, but we'll continue to monitor that situation very carefully. The governor has mentioned we've had 522 new cases, bringing our total to 16,083. Of those, 5,063 are active cases. 106 of those are in a nursing home. 642, at least 642 are in correctional facilities. We have then 4,315 active cases in the community. We have had since yesterday 50 new nursing home residents who've tested positive and 21 new nursing home staff that have tested positive. We have had in our correctional facilities and jails, we've had a number of cases that are coming in. We've had some positives in the Ouachita unit in Malvern, and when the governor mentioned Hot Springs County being one of the top counties in terms of new cases for the last 24 hours, most, if not all of those 85 are associated with the Malvern, the Ouachita unit there. We also have had so far a total of 188 tests positive at the Benton County Jail. And so we're watching these situations carefully. We're taking our usual approach of aggressively testing. Our plan is to test all of the inmates and the staff at the Ouachita unit in Malvern over the next couple of days. And so we'll have more numbers to report. In terms of hospitalized, as the governor mentioned, we've had a net decrease of 7, so we're at 237 there. We have 61 on a ventilator, which is 1 fewer than yesterday. We've had 2 additional deaths since yesterday for a total of 227. We have 10,793 that have recovered. That's an increase of 337 from yesterday. The governor has mentioned our top counties for cases. Those counties that have had between 10 and 20 cases include Crittenden County, Faulkner County, Johnson County at 12, Pulaski County at 16, and Yell County at 19. The governor's mentioned our testing is going well. We have so far not had major issues, although you may have heard about the issues with some of the vials, the media vials that have been distributed by the Department of Health and Human Services, and we are adjusting to that, looking for alternatives. But as of now, our testing will continue. I want to give, lastly, a brief report on active cases and exposures to different types of businesses. We do this analysis about once a week. In terms of our current active cases, 2% of them reported visiting a restaurant within the previous 14 days, 0.4% a barbershop, 2% a church, 0.2% a gym, and 0.4% a hotel or motel. We are going to continue to monitor that just to make sure we're not having any clusters associated with these types of businesses that we haven't opened up further recently as we went into phase 2. And with that, I'll go ahead and turn it back over to the governor.
Let's start with Troy Wells. Could you come and give us a report on Baptist Health, big participant in our effort?
Well, thank you, Governor. Thanks for all your leadership and for allowing us an opportunity to be here today and speak to everyone. I'll just make a couple of comments around our hospitals and hospital capacity, and you saw the graphs and the slides earlier. The good news is that hospitals in Arkansas are getting busier, and the reason that's good is that there was a lot of concern that patients were delaying care through the early months of the pandemic and that they weren't getting the care they needed. So to see patients coming back really is a good thing. We don't want to delay treating chronic disease, and because those things just get worse and create more problems. So we're seeing patients come back. We're able to do our elective surgical cases again, and those are needed procedures. We just had to delay them. So we're doing those again. Critical care capacity is always a challenge in Arkansas, and you saw the difference there in terms of availability and what our current census has run across the state. It's not really COVID related, maybe except for a few exceptions in Northwest Arkansas. For example, At Baptist Health, we've got around 200 critical care beds in all of our acute care hospitals across the state. And last week, we had a census of probably 185 or 190 patients in those units, so pretty busy. But only 16 of those were COVID patients, so COVID hasn't created a critical care capacity problem. We're managing it well. Those numbers ebb and flow in the major hospitals. We're used to managing a high level of critical care patient load. I can't speak for my peers here today, but I venture to say that we're all very adept at moving patients around the state. We receive a lot of patients from around the state here in Central Arkansas and in other areas like Jonesboro and Fayetteville and Fort Smith and Texarkana. Those hospitals are used to working regionally and accepting patients and managing critical care capacity, which is really where you get most of that around the state, is in our metropolitan hospitals. So we're very adept at doing that. We're good at that, and we continue to do that today to deal with those capacity challenges. Again, not new, but just how we're used to doing business. Additionally, we all have surge plans. Those were mentioned earlier. Some of those are short-term. We could create 14 more critical care beds in 2 days. And some of those are longer term if we think there's going to be an extended need for critical care capacity in our state or in the community. We have those plans as well. So I feel like we're in good shape there. And then finally, I just say that in addition to being used to moving patients throughout the health system and across different hospitals around the state, we're also really adept at flexing our services as needed. So we know when we can turn some of these things on and turn some of these things off. That creates capacity from a clinician standpoint and from a bed standpoint. So my main message to you today is hospitals are in good shape around the state. It's a close-knit healthcare community. We communicate with each other on a regular basis. We know where the needs are. We know where we can help, and we don't have a problem picking up the phone and calling one another and working together in a collaborative fashion. And the Department of Health, of course, is there to be that central point of contact for all of us to make sure that we're working well together and there's not unmet needs out there around the state. Thank you.
Thank you, Governor. I'm Chad Aduttle, CEO for CHI St. Vincent. And as the Governor stated, we had the opportunity earlier today to meet and discuss hospital capacity and preparedness. And I want to assure our Kansans that we are more prepared and in better shape as a healthcare delivery system than we've been at any time during the pandemic to take care of patients in a safe way, to keep our coworkers safe, and to keep our physicians safe, and most importantly, to keep patients safe. In terms of the capacity, as Troy with Baptist mentioned, there's still capacity within the hospital systems. Less than 5% of our patients today are currently COVID-19 positive. And overall, we have still 1/3 of our beds capacity available. So again, want to encourage patients not to delay care, whether that's returning to your physician clinic or returning to the hospital, because again, it is as safe a time as it's been to receive care. So thank you, Governor.
Good afternoon, and thank you, Governor Hutchinson, for the chance to be a part of this press conference again today. The situation at the University of Arkansas for Medical Sciences is really pretty similar to what was just described, so I won't reiterate everything that the other CEOs have said. I will say that there are hospitals within the state that have adequate resources but are getting close to being capacity constrained, especially in Northwest Arkansas. And we have been in close contact with the CEOs of those facilities to talk about both short-term and long-term plans for assisting in providing care for COVID-19 patients if those facilities get to the point where they're not able to meet the demands of the hospitalized COVID-19 patients in their geographic region. And in the short term, the capacity assistance that we can provide will be accepting transfers from those facilities. Over the long term, we've had discussions with those facilities about moving healthcare providers to those areas, to those hospitals, so that if Washington Regional or Mercy Hospital You need to expand the number of beds that are capable of handling COVID-19 patients in their facilities, that they can tap into UAMS Human Resources to ensure that that happens. We also at UAMS are essentially back to being fully in business with our non-time-sensitive surgical procedures. And one question that gets asked to me very often that I'd like to address with you is what happens if we have a continued increase in the number of COVID-19 patients requiring hospitalization? Will we go back to where we were with stopping elective surgical procedures as a consequence of that? And my answer to that is that we are in a very different time here on June 21st than we were when the halt in elective procedures was promulgated by the Department of Health. At that time, there were two reasons to halt doing elective procedures. One was to create capacity because we were concerned that we would be overwhelmed. And then the second was the safety issue, making sure that patients, family members, and our healthcare providers were safe in the middle of an epidemic, and with the thought that if something didn't need to be done right at that moment in time, that it could be deferred so that there was not a risk of transmission. What's different now compared to when that was done is we now have much better testing. We now have much better personal protective equipment. We have better means of segregating patients who are getting elective procedures from patients who are COVID-19 infected. So I certainly don't want to speak for the Department of Health, but if there is continued increases in the number of COVID-19 patients requiring hospitalization, the reason for stopping elective procedures won't be for safety issues. I think we have the safety issues addressed. So as long as we can maintain the capacity to manage taking care of COVID-19 hospitalized patients, we don't have a safety need to stop doing elective procedures at the same time. And I think that that's going to make the situation across the entire spectrum of healthcare delivery in the state of Arkansas much more easily managed. Thank you very much for the opportunity to talk to everyone.
Thank you, Dr. Patterson, and with that, we'll take any questions.
What are the numbers in terms of COVID patients who are hospitalized? How many of them require an ICU bed?
Do you have that statistic, Dr. Smith?
Yes, I do. Well, I'm sorry. What I have is the top 10 hospitals. The most hospital, the hospital that has the highest number of COVID-19 patients in an ICU is 17. And of the top 10, it ranges from 17 in an ICU to 5. So that gives you an idea. I don't have the total number. What I have is the total number who are currently on a ventilator, which is a lower number than ICU.
Dr. Smith? Yes.
Smith, can you explain the industry vials issue you referred to?
Yes, we received notification over the weekend that that some of the vials that were sent to us by the Department of Health and Human Services as part of the reagents that they're giving to us for testing were not found to be suitable, and they asked that we not use these. I think there were some national stories on that, and so we're not using those vials. As you recall, the HHS, Health and Human Services, had agreed to send us 90,000 swabs and 90,000 vials of media. And so these are not the only sources that we have for these, but we're having to adjust to that, are actively looking for other sources for the vials and the media, for the time being, we have enough on hand to continue our testing, but if questions come up about that, we, as well as other states, are looking for other sources.
Dr. Smith, do you have a regional breakdown of hospitalizations?
Regional breakdown, I don't have that with me today, but we can get that for you.
Dr. Smith, do you have an idea of the percentage of patients that have been on a ventilator that have recovered versus patients that have died that were on a ventilator in Arkansas?
We have not done that analysis recently. It is a little bit challenging because some of them have been on a ventilator for a long time, and so that number changes. We can certainly look at that, and it has changed over time. Initially, many of our cases were older individuals, especially those in nursing homes, and they tended to fare less well. Our younger patients, those with fewer underlying medical conditions, do not do as well. So it's kind of a moving target. I can't ever give you a completely accurate, up-to-date number on that, because we have people who have been on a ventilator for weeks, and we don't know whether they're going to make it or not, but we can certainly run that analysis and provide that.
Those cases, it does appear to be going, that more people are recovering than dying over time?
I think the better way to look at that is by the type of patients. Typically those who are younger and have fewer medical conditions are more likely to survive whether they're on a ventilator or not.
Yes, Jay.
I guess, what do you guys make of President Trump's comments on the concept even of backing off of testing, or kind of holding back on that?
Well, clearly we're not backing off testing. We are accelerating our testing. We understand how important that is, and we do recognize that you're going to demonstrate more positive cases when you test more, but that's exactly what we want to know, because that's how you deal with the spread of the virus. And so we continue on. President Trump indicated he was joking. I listened to it. I thought it was a somewhat of a flippant comment, but everybody needs to understand how seriously we take this and how we are going to continue to expand testing.
He said he had told his administration to back off testing. Was that, you've spoken to him and the Vice President multiple times during this, is that a directive he had ever indicated to you?
Oh, absolutely not. In fact, I was just on a call with the Vice President. Actually, the question was raised, and he reiterated, just like he has always done, we are focused on testing. We want to encourage testing, and they're focused on delivering testing supplies to the states. And so it's clear the national policy is to expand testing. And there again, you have to look at what is the action, what is the true policy versus just what the words are. And here, the national policy is to expand testing. Now, as Dr. Smith pointed out, we actually, we're expanding testing, but so are other states expanding testing, and the need for testing is continuing. And so there's a pressure point there, and I hope that supply chain can continue, but it's been very steady, and it's been growing over the last couple of months, and we just hope it will continue to do that with national leadership.
China halting imports from Tyson specifically, I guess, is there any reaction to that? And then is there anything being done, at least from the Department of Health standpoint, on monitoring what they're doing, or is there even a point where you guys come in and say, like, shut it down, clean it up, maybe change your procedures to, X, Y, Z?
Well, China's action is very troubling to me. You look at processing plants all across the country, and they've had outbreaks in different processing plants, and for China to make that decision on one plant in Springdale is not reasonable in my judgment, and it's also not a health risk. There's absolutely no health risk in the product that comes out of there. That's scientific, that's data-driven, and so I don't know whether China is playing politics or just making bad judgments, but that's not good and not helpful at all in our relationship. In terms of the plant facility itself, Dr. Smith can comment, but I've seen how much the poultry industry is doing, and the challenge is that every worker leaves the plant and they go home, or they go to the store, or they go about life, or they go to church. And so there's a lot of different factors in exactly where the increased cases come from. Dr. Smith, did you want to elaborate?
I agree. We've seen a number of the poultry-related businesses actively go test their workers so that they can identify those who are positive, those who are negative, those who are exposed, those who aren't, and to try and take action. So I'm comfortable that we're doing a lot of things to address that. We have a CDC team up in the northwest part of the state to give us further guidance and help us with messaging. And so we'll do whatever we need to interrupt chains of transmission in that part of the state, including continue to work with poultry-related businesses. But again, what the governor said, there's no risk from products that are coming out of those plants, so I'm not sure who is advising the Chinese right now.
Let's go remotely. Is there a question remotely?
Yes, Governor, good afternoon. It's Neil Gladner in Hot Springs, and this question is really for Dr. Smith about the Washita River unit. The Corrections Department website says they hold have the capacity for over 1,700 inmates, and it's an intake facility. So I'm wondering a couple of things. Of those 85 positives, is it thought that maybe that was a new inmate to the prison that brought it into the prison? And of the 85 positives, if you know, how many more tests will you have to do? And are they asymptomatic? Was that a surprise down there?
We're still gathering information on the Wachita unit. We did learn over the weekend of symptomatic patients, and so made the decision to go ahead and be very aggressive in testing over the weekend. As of noon today, we had tested about 800. We still have many more to go. Results are just starting to come in. We'll know more as we go along. But again, this is an evolving situation, but we're taking a very aggressive approach with it, just as we have with the other Department of Corrections facilities. As soon as we've learned about cases, we've gone in and tested all the inmates and all the staff over the shortest period of time that we were able to do that.
Can you say a positivity rate of the 800 yet, Doctor?
No, don't have that information yet.
And a lady remotely.
Hi, Mercedes McKay with Channel 11. I know last week the state received a shipment of N95 masks. I spoke with a local dentist office in a rural area of Arkansas, and I also spoke with David Roten with Arkansas Medical Society, and both of them are saying there is still that steady need of PPE. But I know, for instance, Arkansas Medical Society does not deliver specifically to places like dentist offices. So my question is Arkansas still in a PPE shortage? And then how can those rural areas get the necessary PPE?
Let's have Dr. Smith, why don't you address that? Then I'd like to have Troy, maybe from a hospital standpoint, talk about where you are in PPE.
Overall, we are not hearing reports of large shortages of PPE. There may be particular practices that may have trouble sourcing those. I do want to remind all of those in practices, whether it's hospitals, clinics, or dental offices, that we do have the Battelle decontamination unit that's been cited at the that's located at the Goodwill Industries facility in South Little Rock, and they will offer free shipping, free decontamination. They can decontaminate N95 masks and get those back to the facility within 72 hours. It is completely free to the facility. All they have to do is set up a free account so that they get the masks back that they sent. And those masks, those N95 respirators or masks, can be decontaminated up to 20 times. And so that really can reduce the need for N95 masks by a clinic if they utilize that free resource in the state.
There was a period of time, probably March, April, early May, where PPE was still, there's a lot of nervousness around having enough and what happens if things continue to grow in terms of volumes with COVID-19, and how do we protect our staff, and when we start doing elective cases, and that uses a lot of PPE. Our health system has continued to just acquire as much as we can along the way, even when we thought that COVID-19 cases were going down in Arkansas. We just said, we want to play it safe and continue to plan for the unknown. And so we're in really good shape right now with PPE. We have been able to, in addition to moving PPE to our rural community and our hospitals and our physician clinics. We've been able to help supply some non-Baptist Health affiliated clinics and nursing homes around the state with PPE when they've been short. So, I would just tell everybody, providers in communities, to talk to one another and find out if there are organizations or institutions in your region that have the ability to help you out. But just keep ordering and keep planning on the need for more and more PPE throughout the year.
Thank you.
And I will add that I spoke to Washington Regional Medical Center today. They're in good shape on PPE. Hospitals in Northwest Arkansas have that. We continue to monitor it. As we identify needs, then we're happy to respond to those. Is there one more question remotely?
Governor, this is Andrew with AP. Going back to the hospital and ICU capacity numbers, I wanted to see if y'all had some context on that, of how does that compare to a week ago, a month ago, or even the start of this latest spike in cases that we've seen since May. And also,
just a second, Andrew.
Yeah.
So you're talking about how does it compare the available hospital space now versus a month or so ago?
Yes.
Okay.
Separate question. There was some discussion in legislative committee this morning with Dr. Patterson, and legislators were asking about the impact that requiring masks would have on the modeling that they've predicted for September. Wanted to see if you've talked with hospital administrators there about what their recommendations are on whether or not the state should have there should be mandatory mask policy or directive.
In terms of the available hospital space, obviously it's hard to compare for a month or 2 months ago before we re-engaged elective surgery. So there was a great deal of capacity because our COVID numbers were low and we were not doing elective procedures. That's changed now so that we are having an increased number of COVID patients, as well as we're doing elective procedures. But as you can see from the pie charts today, that there's still probably about a third capacity that can be utilized. In speaking to the hospitals in Northwest Arkansas, they have available space. They're good, but it is tight, and that's comparing with having continuing to do their elective procedures as well. So we continue to monitor that. In terms of the face mask, and I'll let anyone speak to that. I think it would be the judgment of any medical professional, and I will agree with it, that more people that wear a mask, then the least risk of transmission. And that's why I've encouraged it from day one. The first day CDC came out with the guidelines, I put on my own mask, realizing that I wanted to set the right example, and we set forth statewide guidelines last week to continue to encourage and lead people to wear masks to protect themselves, but more importantly, to protect others. We continue to look at that, recognizing that there is a scientific basis that will help reduce the transmission. Dr. Smith?
Not to overstate the point, but in a mathematical model, whether you require a mask or not is irrelevant. What's meaningful is what proportion of the population actually use a mask and use it correctly. And if you get a high usage rate, whether or not you have a requirement, you are likely to have decreased transmission. And requiring it but having a low rate of usage will give you higher rates of transmission. So again, it's not the requirement versus not requirement that affects the mathematical model. It's what proportion of the public or what portion of certain populations and what in certain settings actually use them.
Let's come back to the table. Yes.
I have a mask question. I was wondering why the health department has changed the recommendation for masks for students on a bus. They apparently have decided that they don't have to wear them? Previously, the directive was that they did need to wear them.
I would need some more specific information on your question to be able to answer that. Generally, in situations where a physical distance of 6 feet or more can be maintained, masks are considered optional. We consider masks to be contraindicated in children less than the age of 2, and between the age of 2 and 10, it's optional for some pretty obvious reasons. Sometimes it's hard to get those younger children to keep the masks on. So amongst those children, it would be preferable to create a situation where you have the physical distancing rather than trying to count on masks, which are not likely to be to stay on the face. But I'd need to know some more details exactly.
Policy that has come out for students, for teachers, states that it's now recommended but not required.
Right. Again,
students over 10.
Our preference would be to create situations where you have that physical distancing so you don't have to rely on masks.
Specifically on a school bus, it says in the directive.
Correct. We would prefer a situation where you can achieve that physical distancing rather than count on the mask or need the masks to protect those students. Obviously, if you can have physical distancing and masks, that would be certainly wouldn't hurt. But to create a situation with school children where you have to have masks when you could have set it up where you could have the physical distancing instead. Again, we can talk more about this offline, but there's no change in the concepts. It's just the application.
Is the concern that by requiring people to wear masks, there'd be some kind of backlash where people would be angry about a requirement and then choosing not to wear masks?
I think that is exactly the argument. You know, how do you encourage people to wear masks? I think we're taking it by providing the guidelines. It's not really any different than the churches. We provided guidelines to the churches for them to follow, and by and large, they are doing that. And I think we've got a large level of compliance because we set that as a guideline and educating the faith community as well as educating the public.
My question is for Dr. Patterson. What are all the factors that you guys are entering into that modeling? Because that worst case scenario of potential 250,000 cases is about 11% of the U.S.'s total cases, what they have currently. So I'm just curious as to what you're looking at into seeing that extent of a projection.
Yeah, so the model is a collaboration between the Bozeman College of Public Health at UAMS and the Arkansas Department of Health, using information from the Arkansas Department of Health. The information is that's used to make those models is looking at the incidence of cases, looking at what we call R0, which is the transmissibility from one individual to another, a number greater than 1, meaning that each infected person is more likely to infect more than one additional infected person. The difference between our model and, for instance, the Seattle model is that we are looking at data specifically in the state of Arkansas, whereas the Seattle model is looking at national data and extrapolating it to the state of Arkansas. So when we look at rural transmissibility in the state of Arkansas, that's based on previous rural transmissibility of COVID-19 in the state of Arkansas, rather than extrapolating rural transmissibility elsewhere in Wyoming to the state of Arkansas. And so that's the major difference. I say with respect to the model, it's only a model. It's a prediction in the same way that hurricane forecasts are predictions. When the forecasts start lining up in the same direction, then you need to start thinking about moving out of town if they're all lining up on your town. Right now, the models are all lining up on a peak sometime in late September or October. So that seems more and more likely. The real question is the magnitude of the change. And the Seattle model is predicting a 5 to 10-fold increase in the number of cases. Our model is predicting a 30-fold up to a 50-fold maximum increase in the number of cases. That's all assuming that we don't do any interventions that either increase or decrease the probability of COVID-19 transmissibility. So, I would say the main difference in our models compared to other models is using state-based data. It's a model. It gets reassessed over and over again. To put that in perspective, back in March, our model predicted that there will be 15,000 total cases in the state of Arkansas by the end of June. We missed that by 1,000 or two. It's been 16,000 and growing. But our model at that time was the high end of models predicting the number of infected patients back when we started in March. So there's some reason to have some confidence in our model. It gets reevaluated on a weekly basis. But it's only a model and it's only a prediction.
Yes.
I have a question for Dr. Smith about testing in Washington County. So Washington County has been significantly under-tested compared to Benton County. If you look at June, Washington County tested 3% of its population compared to 7% over the same time period. In Benton County, I believe its average daily percent positive rate was 28% positive, which is way higher than the 5% recommended by the World Health Organization and 10% that we cite here every day. So why is Washington County testing so low with a known outbreak, and what is the state doing concretely to address that?
Well, address that in two ways. One is we've been encouraging testing, trying to make testing as available as possible in both counties. At our local health units, it's available Monday through Friday. We've had off-site testing events. We've also been partnering with our clinical providers as well as some of our employers to offer testing. Now, in terms of Benton and Washington County, if you really look at how they function economically, they're a unit. And so whether you're testing this side or that side of the county line, as long as we're reaching that population, making the testing available to that population, that has been our focus rather than trying to balance it exactly between those two counties, recognizing that this is really a unit, an economic and in some ways a social unit, although there are specific populations within those counties. And we've certainly had some targeted outreach to our Latino community, to our Marshallese community, et cetera. Those have been more important to us than specifically balancing it across a county line.
Any question?
Yes, Governor. I think it's mainly for Dr. Smith, though.
Okay.
Could you provide an update on the contact tracing and whether or not it would be possible to get an age breakdown regionally of the new cases that are coming in?
This will be the last question here.
Doing an age breakdown of the new cases in the last 24 hours is difficult just because it takes a little while to do that analysis. I do have an age breakdown from active cases. So those are all those who have been new cases within basically the last 14 days. And our age breakdown currently is 13% are under the age of 18, 14% are 18 to 24. The largest group is our 25 to 44 year range, and that's 37% of the cases. The second highest group is the 44 to 64 age group, and that's 26% of cases, and only 10% of our cases, fortunately, are 65 years of age and older. Now, I need to contrast that of our deaths, 71% are in that older age group. So we have seen a sort of a move towards not the youngest age group, but that sort of the age group of 25 to 64 representing most of the cases. And fortunately, we've seen a decrease in the percentage of those 65 years and older because that's the group that is at the highest risk for adverse health outcomes.
Thank you, Dr. Smith, and I want to thank our hospital leaders for being here, both for the previous conversation and for being here for our public gathering. With that, we will be convening tomorrow in Mountain Home on northern Arkansas for our daily COVID-19 update, and be back here in Little Rock on Wednesday. Thank you. Have a good afternoon.